Maybe let me introduce you to Dave Mackenzie, who is the teacher of our newly launched point-of-care ultrasound masterclass. So, hey Dave, how's it going?
Hi Franz, how are you?
Hey, pretty good. Where are you joining us from?
I am in sunny and hot Portland, Maine in the United States today.
Nice, nice. And I'm in Salzburg, Austria, the headquarters of MedMastery. So, Dave, do you want to give us a little bit of background about yourself, and maybe also then as we introduce Martina, who's also on this call, whom you don't see yet, but she's in the background making sure that things are working well. Do you want to give us a little bit of background about yourself?
Yeah, sure. So I work at Maine Medical Center in Portland, Maine. I'm a professor of emergency medicine at Tufts University in Boston. And I got into ultrasound when I was in my residency training, postgraduate training, about 10 years ago now. And you know, it didn't totally click for me at first why this was going to make such a big difference in my career and my practice. And where it really started to sink in is in some of the global health work that I was doing, when I really started to understand how powerful point-of-care ultrasound could be and how it made me so much of a better clinician. And from there, things really took off as I started to understand the difference that it made to me, as well as to my patients. And then I ended up doing an ultrasound fellowship after my residency training, and then came up to Maine where I helped direct the ultrasound program here. And I love teaching and sharing ultrasound with others. So I do an extensive amount of teaching, both with our trainees and around the world. And it's really exciting to help bring this to the MedMastery suite of courses, because I think it's something that the users are going to love.
Awesome, awesome. Hey, as I said, we also have someone in the background. That's Martina, who's from the MedMastery team. She'll just be making sure, screening all your comments and everything so that we don't miss anything. So you might hear her voice. You might hear her say something, mention a comment on Facebook. So we're live on Zoom, and we're also live on Facebook. And people who are watching on Facebook see us with a little bit of a time delay. So sorry for that. But I think you're going to have a good experience as well. And we're going to have polls as we go along. Dave already pulled up the slides, and what you see here is the landing page of a newly launched point-of-care ultrasound masterclass. Dave, do you want to say a little bit about the masterclass and what we're intending with it?
Yeah, so this class will really help bring people to the kind of advanced ultrasound applications that it's sometimes hard to get to on your own. So there's, you know, one of the hard parts about ultrasound is it really is a mentorship model where you need someone with experience to help guide you through not just how to acquire the images or interpret them, but also how you're going to use them and when you're going to use them. And there's no substitute for having an expert kind of guide you through that process. You can Google pictures on the internet and see an example of an abnormal or normal finding, but you need someone to help put it into context for you and understand why you'd use a certain application when. And that's really what we try to do in this course, and introduce an array of applications for all different types of clinicians. No matter where you practice, there's something that's relevant to you. And regardless of what you do and how you do it now, ultrasound makes you better. And this is the type of material where we'll help get you there with this course.
Awesome. Yeah, that's awesome. So the plan for this webinar is that we're going to present you with a couple of cases taken from the webinar. You get the chance to interact, to kind of take a guess, and to poll, do the poll. And so, yeah, Dave, let's just get started on the cases and let's see what we're going to learn from you.
Yeah, so this is just a representative chance of some of the pathologies that we will go through in terms of both how to recognize them, but also when to look for them. So we'll take a look at some sample kind of cases, the sorts of things that you'll learn how to diagnose in this course and feel comfortable making the diagnosis of. All right, so here's the first case. And this is a little bit more challenging because you don't necessarily know where in the body we're looking, but you can see a few things. If you have any ultrasound experience, you see we've got a curvilinear or low frequency abdominal transducer You can just take a moment and kind of look at the type of structures. So take a moment. We're looping through the clip here and seeing a few different things. And then let's take a look at some of the possibilities.
So yeah, sorry. Go
some
ahead.
Potential answers here, and I believe you'll have access to the poll to be able to make your call on what you think is happening here.
Hold on, I'll try. I'm going to choose that launch poll. So everyone gets the chance to vote. So please cast your vote. We're very curious to see what you think that this is. Yeah, so 71% have voted. Okay. Awesome. So yeah, so I'm going to end 3, 2, 1, and poll and share results. So this is what people think.
So we've got a range of findings here. I like what I'm seeing. Let's just go back for 1 second and take a look at the clip. The correct answer here is what the majority thought. This is a small bowel obstruction. And so this is the kind of thing that at the conclusion of the course you'd be able to recognize without any difficulty. So we're on the anterior abdomen here. We can see that there are fluid-filled tubular structures. We've got some of the markings that indicate that this is bowel. There's no peristalsis through this bowel. And if you look down here in between 2 of the bowel loops, you can see that there's some free fluid. So this is a finding, this is a diagnosis that you can make in seconds in a patient who comes in with an abdominal pain. You can rule in a bowel obstruction and move on with their care from there. But depending on the situation, this could also be an ileus if you didn't know what you were looking for. So that's part of the thing that we get at in the course is understanding why this would be a bowel obstruction and not an ileus and how that would be context dependent. So well done for everyone who nailed it. Good work.
Hey, and by the way, if you have any questions, either if you're joining us on Facebook or on Zoom, go to the chat, leave a comment, ask us anything. This is the opportunity you have to ask Dave, who is a real expert with so many years of experience. Yeah, so Dave, let's move on.
Let's take a look at another case. So here you can see this structure. Again, the image is obtained with a curvilinear or relatively low frequency transducer here. And so we're wondering, what is this structure here? What is the diagnosis? And then for bonus points, you can ask yourself, what is this back here and what's happening? Because that might be a clue to what the diagnosis is. And you can take a look both at the appearance of this finding as well as some of the internal things that you notice about it, and that might help clue you into what's going on.
Okay.
Take a look at our possibilities here.
So these are the possibilities. I'm going to launch the poll. So please cast your vote. What do you think this is? Okay, we have 13%, 20%, 40% of the participants have voted. Come on, you can do this. Tell us what you think.
At the end of the course, it'd just be bingo bango. You know the answer to this.
Oh, bingo bango. I remember that expression from recording. We had a lot of fun recording the course in Salzburg. Hey, okay, so 66% have voted. Not everyone has cast their vote. I'm just going to end the poll and share the results. This is what people think.
Okay, so we got a range of choices again. This is good. Let's take a look at this structure here. So again, this is a little harder to do ultrasound when you don't know exactly what's going on the body or where you are on the patient. But this is a pneumonia. This is a consolidation. So there are a few things that tip you off to that's what you're looking at. One of them may be that you're actually seeing some movement back here from the heart because we're creating an acoustic window through the lung that's allowing us to see some cardiac movement back there. But we have this irregular sort of tissue-shaped density, and I think that's part of the reason we had some people think that this might be a spleen. You can see that there's some black material, which indicates fluid running through it, and that might be why there was a guess of a splenic laceration. But these little white areas here are bronchograms, and there's some air movement through them, which is one of the findings that you would expect to see in a pneumonia. And lung ultrasound is one of the most powerful applications for point-of-care ultrasound, which for years people didn't realize we could use this, but it's actually a transformative application that you have to know how to be able to use. One of the things you'll learn in this course is that the chest x-ray, while not dead, is a far inferior test to lung ultrasound when you're looking for pneumonia. And you can be able to make this diagnosis in a minute when you go and put the probe on a patient's chest. All right, let's do the third question here. Switching gears a little bit. What do we have here? All right, so we've got sort of this hyperechoic, bright structure here. And the finding of interest is in this area up here. So think about what this might represent. And let's go to the poll.
So again, if you guys have any questions, ask them below. You have a Q&A button where you can ask questions and we'll answer them for you if you want to know any additional information. But I'm going to launch the poll. So let's see. Launch poll. And so guys, please let us know what you think this is. Okay, people are voting. 56% have voted. Hey guys, sorry on Facebook you can't vote, but we're trying to make this an engaging and fun interaction as well. So you can always kind of answer the questions in the comment section if you feel like it. So come on, give us your vote. Tell us what you think. 56% have voted. Guys, we can do better than that. Okay, good. Let's end the poll. Share results. So this is what people think. Tendonitis, 22%. Tendon rupture, 44% is the winner. And 33% think joint effusion. So, Dave.
Okay, let's take a look. Some of the features of that, that make this what it is. All right. So this, again, context is everything, but we're using a high-frequency linear transducer looking at a superficial structure. And what we have here is we're on the Achilles tendon. So it's coming down here and inserting on the calcaneus, the hyperechoic bony structure. And tendons normally have this very fibrillar pattern, which you can see right here. And then right in the middle of this tendon, right as it inserts down the bone, you see some black material or hypoechoic material, which indicates fluid. And you can see that it extends down towards the base of the calcaneus. And this indicates that we have a tendon disruption here. So we have an Achilles tendon rupture. And certainly my experience in medical school was that there's this tiny amount of training devoted to musculoskeletal medicine. And yet, within acute and primary care, musculoskeletal complaints are among the most common that we see. And ultrasound really makes patients happy with these complaints as well as clinicians because we can be more specific with what's happening to them. We can give them better guidance about the exact diagnosis. We can pick more subtle findings up that we may not always recognize on X-ray. And so people are visual and they love imaging tests, and we love imaging as well too as caregivers. And when you can actually look at the structure that hurts and say, this is the problem, and show them their problem, be able to give them very specific guidance on what's happening, it helps them understand what's going on, helps avoid unnecessary X-rays, and helps you figure out where they need to go next and what's happening. So I love this for patients with MSK complaints.
Cool.
All right, let's take a look at another one. Again, we'll shift gears a little bit here. We're using a high-frequency transducer again. And just take a moment to sort of drink this in and see what we've got here. The operator is fanning through the organ here, which is good. Getting a look at all of what's involved. And let's take a look at our possibilities. Oh, then they put some color Doppler on. Maybe a clue. All right, so what's the diagnosis here?
I'm going to start the poll again. Okay, so please tell us what you think. Is it hepatocellular carcinoma, ruptured globe, renal laceration, testicular torsion, or cirrhosis and ascites? What do you think? People are casting their votes. Okay. More votes, please. Cast your votes. And I'm going to close this in 3, 2, 1. Poll. Okay. Share results. This is what people think. Most people think it's testicular torsion with 67%, followed by renal laceration, 25%. So, David?
You guys got it. So this is indeed a testicular torsion. Now, you're missing knowing that where we're putting the transducer on the body, but good job regardless. So what we can see here is we've got this irregular structure. So we've sort of got some mixed echogenicity, sort of some dark areas and then some areas that have some echo in it, surrounded by an area of hypoechoic fluid corresponding to some of the edema. And if you were to compare this to the unaffected testicle, we'd probably see that it was enlarged as well too. And then when the operator puts some color Doppler on, they see that there's no flow. So this is a really advanced testicular torsion, someone who was a late presenter. But the real advantage of a point-of-care ultrasound study is that you can make the diagnosis instantly. So a lot of users don't necessarily have access to 24-hour imaging and certainly not necessarily even 24-hour ultrasound. But with a bedside scan, you can make the diagnosis to go with your clinical impression so that when you call to transfer the patient or to consult for the patient, or if you take care of them definitively, you can be that much more confident you know what's going on and get them to where they need to go to get this problem fixed.
Mm-hmm. Yeah, I think this topic is really covered very well in the course, and I think you're going to learn all about scrotal ultrasound there.
So let's take a look at another one.
Yeah, let's finish this up. This is going to be our last case.
So we've got a bunch of echo material that we'll cover from a point of care perspective. And now we'll just take a look at this patient, see if you can figure out what the diagnosis is, even without any clinical information. So we have an apical 4-chamber view of the heart. Take a look. What do you think we have here?
Image quality is not ideal, but...
That is real life. Your patient is short of breath, sitting up. This isn't the echo lab anymore.
Yeah.
What's the problem here?
So, you start the poll. So, those of you who are on Zoom, locked in on Zoom, please cast your vote. Endocarditis, myocarditis, pericardial effusion, mitral regurgitation, or mitral stenosis. So 56% have voted. Please cast your vote. Votes are coming in. Okay. I'm going to close the poll in 3, 2, 1. And poll. Share results. So, majority, 38% say endocarditis, followed by pericardial effusion, 31%. So that's pretty tight. So, David?
So let's take a look. So the key finding here is that this patient has, come on, Beast. The key finding here is that this patient has a vegetation sitting on the mitral valve. So if you knew that this patient, as you might as a clinician, knew that they were presenting with fever, general sense of malaise, and they adamantly swore that they had never used drugs, had track marks, needle marks up and down their arms, you might be able to recognize that this patient, that much more easily, that this patient has a vegetation there, which is highly suggestive of endocarditis that's sort of flopping back into the left atrium there. So for those of you who said pericardial effusion, I like that idea. That's a good thought. And you know, when you look around the edge of the pericardium here, you might wonder, is there a little bit of fluid here? And then when you come up here anteriorly, you might think the same thing. Is there some fluid? That is absolutely a reasonable thought. But one of the things that we talk about in the course is that you really want to try and confirm your findings with multiple views. And so I would say that this is certainly suggestive that we might have a pericardial effusion, but we want a little bit more information to be sure. So I would say that's a reasonable thought as well too. But the key thing we're looking at here, and the thing that you would know as the person taking care of the patient, is that this person was high risk for endocarditis. And if you saw this finding on their echo, that you would be doing your utmost to convince them that they need to stay in the hospital to get this addressed. And so often these folks want to leave. So that's just an example of one of the things that we'll cover in the point of care echo chapter.
Awesome, awesome. Hey, this was our 5th case. And now, if you guys have any questions about other pathologies or anything or the course, feel free to ask them now. And we'll be waiting for your questions. Otherwise, maybe David, we want to show the next slide regarding the offer that we currently have. So the pro membership, the yearly pro membership is currently 50% reduced. So you can save a lot of money if you subscribe this week. This is to celebrate the launch of this course and also the anniversary of our Intelligent Thursday newsletter, which is a weekly newsletter that we send out with inspirational posts, instructive videos, and that kind of stuff. And so, yeah, this week, 50% off, take advantage of it. And so I see a question where someone's asking about a lung ultrasound and what they'll learn if the course also offers a chapter on lung ultrasound. Maybe you want to say a little bit about that, David? Yeah,
so chapter 2 of the course is all focused on lung ultrasound, and we will cover a range of topics within lung ultrasound. Certainly we'll talk more about the diagnosis of pneumonia, which we had the example of earlier. But we'll also talk about a range of other pathologies. What does ARDS look like on ultrasound? What do viral infections look like? What is sort of an overall approach to evaluating the patient who is dyspneic and you don't know what's going on? And I think, you know, the evidence basis for lung ultrasound has just expanded. And if you're taking care of anyone in primary care, acute care, critical care, and you're not using lung ultrasound, you're missing out. So it's one of the things I do most commonly on a day-to-day basis. And absolutely, we'll spend plenty of time talking about lungs in this course.
Awesome. How about vascular? We have a question about vascular Doppler.
Yeah, so one of the things as you move from a basic point of care ultrasound skill set and start doing some of the more advanced applications is that you do need to start using some more Doppler applications, both color Doppler, but also spectral Doppler. And we will touch on those things as applicable in this course. So in the volume status chapter, we'll talk more about calculating cardiac output and how that looks to me. For some of our applications, when we're looking at making the diagnosis of DVT or of dissection, there are a variety of situations when we're going to need to use some Doppler. And, you know, point of care ultrasound is different from a comprehensive study or the way other specialties may use ultrasound. And so we have our own particular approach within the point of care world about what you need to know, but you will absolutely need to acquire some Doppler skills. And that's one of the things we want to share in this course as well too.
Awesome. Question from Dragan, who asks, does it mean that we do not have to do transesophageal echo if we already can see vegetations in transthoracic echo?
So great question. So this is one of the things that, you know, we will talk about in the courses. A big part of being a point of care ultrasound user is understanding what you can and can't answer with a bedside study. And that's something where that sort of teacher and mentorship model is so important. So the specificity of a transthoracic echo, whether it is done by the echo lab or by a point of care user, is actually quite good. However, the sensitivity is imperfect. So a high probability patient still requires a transesophageal echo if your transthoracic echo is non-diagnostic. Whether they need a transesophageal echo in addition to a transthoracic is going to be specific to where you practice and the person who's taking definitive care of the patient and making a decision about whether this is going to be treated medically or surgically. So the short answer is, it depends.
Mm-hmm. You mentioned sensitivity and specificity, and the great mnemonic that I've learned in clinical epi class is SPIN. SP stands for specificity. Specificity is good to rule something in, so SPIN, and SNOUT. SN stands for sensitivity, and sensitivity is good for ruling something out. SPIN and SNOUT. So this means that if you have a test that has high specificity, it's good for ruling something in. And so in this case, what David said, transthoracic is great for ruling something in. Transthoracic has a great specificity, which means that you can rule something in, but it doesn't have a great sensitivity, which means that it's really not good for ruling something out. So Dragan says, thank you, you're welcome. Any important take-home message before we end this webinar? David, any kind of nuggets, pearls, anything you want to share with people before we go?
I think the biggest thing is, most people who become ultrasound users sort of have an aha moment when they get it, and they understand how much better of a clinician they are once they understand how to use ultrasound, and they can't imagine practicing without it. So I'm excited for everyone to acquire those skills, and we'll see you in class.
Awesome. Hey, thanks so much, David, for taking the time to do this. This was awesome. This was fun. I think we're going to do this again. And yeah, everyone, hope to see you in class, and have a great day.
My pleasure. Have a good day. Thanks for coming, everyone.